There's just really an enormous number of choices that we have nowadays to treat chronic myelogenous leukemia. It's really been an exciting evolution over the past decade and a half. And really, when I started off, there was only bone marrow transplantation, interferon. Those were our treatments for CML. And really, interferon not very effective, transplant effective, but certainly with many potential side effects, including life-threatening side effects. And here we are now with half a dozen different choices to treat CML, starting, of course, with the original TKI, imatinib, Gleevec. That was the only one we had at one point, and certainly anyone with CML we tried to treat with imatinib. But now we have second-generation TKIs, such as dasatinib and nilotinib. Further beyond that, we also have bosutinib now and ponatinib. So in one sense, it's almost confusing. Where do we start off? How do we treat our patient with CML? And I think there are still many people who like imatinib, the original TKI. They like it because they said, we've used it for many years, we've had good results with it, it's cheaper, why don't we continue using it? But I think there's enough convincing evidence nowadays that the second generation TKIs not only have a faster, deeper response, but long-term, fewer progression to advanced phases of the disease, fewer accelerated and blast phase cases. So I think more and more, most of us are starting off with these second generation TKIs. A question about stratification has arisen, meaning, are there patients who are lower risk in whom we might start off with imatinib rather than a second generation TKI? And there are certainly people who follow that strategy, looking at risk stratification scoring systems, such as the Sokal score for our patients with CML. But nonetheless, I think that many of us in the field are still going to the second generation TKIs first, because based on the data we have, based on extrapolation of when we retreat patients who have failed imatinib, the outcome is better with the second generation TKIs. The question of dosage of the TKIs is one that goes all the way back to imatinib. And I believe to this day, the group at MD Anderson firmly believes that 800 milligrams rather than what we all call the standard 400 milligrams gives a better outcome. I think there are more side effects, though, with increasing doses of the TKIs. And I think that we really haven't reached a point where we're able to model a particular dose for an individual patient. And what usually happens is if a patient has side effects from a particular TKI, and these are not horrible side effects, but relatively tolerable ones, we might try ameliorating them with a lower dose, still while hoping to maintain the efficacy of the drug. In terms of what dosage we use for our three first developed TKIs, that is imatinib, nilotinib, dasatinib, I think that most of us start off at the labeled dosage of all of those drugs. But I have to say that if patients develop side effects, we might lower the dose somewhat. And the problem is we don't have a lot of good data showing us what happens when we lower the dose of these drugs. I can just tell you from personal experience that I've had patients who have had side effects that were really unacceptable to them. I wanted to maintain them on the drug, and by lowering the dose slightly, we were able to ameliorate those side effects and continue treating them.